May I now invite Dr. REBIKA, who is an assistant professor with us at Dr. Rajendra Prasad Center, to present her talk on neuroimaging. इसमें लगा दो, इसी में लगा दो. नहीं, ये सर की talk है.
So a very good morning, everyone. Coming to the discussion, bringing the discussion to neuroimaging in neuroophthalmology. So you see that neuroimaging actually has undergone quite a lot of change, and it has, dramatically advanced in the past few decades. Slideshow. Yeah. So dramatically advanced in the past few decades, and there are a lot of techniques which have come up. So why should we know about these techniques? Because technically it's a job of a radiologist. But what happens is that if you're aware of these techniques, you can guide the radiologist as to what kind of imaging protocol he can use in your patient, and also interpretation becomes quite easy. So the questions are what to order and when to order. So just before we go on to the topic, remember that these imaging scans are provided in 3 sections. One is the axial, when we are looking from above; coronal, you're looking from front; and sagittal, where you're looking from the side. Now CT scan, MRI. Now CT scan uses the ionizing radiation to evaluate the tissue density. Now this radio density, just to simplify things, remember that bone has the highest radio density, it appears white on CT. Air has the lowest one, so it appears black, and rest of the soft tissue that you see has some shades of gray in between. So what are the specific indications for CT where, CT is preferred over MRI? It's the bony lesions, when you want to rule out some sinus lesions, traumatic cases, hemorrhages, when the MRI is contraindicated, like metallic implants and claustrophobia. So look at these pictures. A case of trauma comes to you, orbital trauma, head trauma. So the investigation of choice is a non-contrast CT of the head and orbits. So you can, very well see these fractures involving the optic canal, and that can explain your traumatic optic neuropathy. Then multiple orbital wall fractures. You can see the prolapse of the soft tissue into the maxillary sinus in case of a floor fracture, and that might explain why there's a restriction. The patient is having some restriction or limitation of movement in upgaze. And also sometimes you might get an idea about the soft tissue. So here you see an extensive medial wall fracture and a little optic nerve avulsion. Okay? So, and then you have newer techniques like volume rendering techniques. Now this gives a beautiful 3D reconstruction of the bony, visual illustration of all these bony structures. So you see these fracture lines running around. So it gives you an idea about the surgical planning and management. In our orbital pathologies, well, we have a patient who presents with a proptosis in the left eye. You do a simple CT and the diagnosis is glaring at you. So you see the muscles are so hypertrophied, it's thick, so it's a case of a thyroid eye disease. Another case, she was a 2-year-old female who had a bilateral disc pallor, severe disc pallor. We got an MRI done. MRI just showed thinning of the nerves, but we could not find what the cause was. So then a CT was done. So CT indicated these hypertrophic, sclerotic bones. So this was causing the thinning of the optic canals, and this was a case of osteopetrosis. Then you can have intracranial pathologies, gross pathologies you can rule out, on CT. So it's preferable to use a contrast-enhanced CT in such cases. So there can be an occipital infarct. Now here in the second image, you see a suprasellar mass lesion. Now the third image is a little interesting. We do not know what to see because we are not radiologists. But when we provided the clinical history to the patient, that the patient had a right-sided vision loss and some problem with the, diplopia and all. So now what you see over here, the cavernous sinus, this side is homogeneous, but here you see some filling defects. So this was a subtle sign of cavernous sinus thrombosis. So that's why it's important to provide clinical information to the radiologist. Now coming to MRI, the preferred modality, it is the best the modality for soft tissue resolution and also does not provide a radiation exposure. So important, the 2 common sequences that you use is a T1. T1, to simplify things, the fat is bright, water is dark. So it gives you the anatomical details very nicely, it shows. And T2, it identifies the pathology, especially edema. Why? Because the water is bright in this. And contrast-enhanced MRI, you use IV gadolinium. So whenever there's a breakdown of a blood-brain barrier, like in case of tumors, you see a post-contrast enhancement. Okay. Then now these are some newer sequences which are of relevance to us as neuro-ophthalmologists. Now what is a flare? Flare means fluid attenuation. So as I told you, water is bright in T2. So what does flare do? Flare actually suppresses the signal from the normal water, that is CSF. So this is a flare, flare suppressed image. So CSF is bright here, but here it has been suppressed. So what's the advantage? Is that the demyelinating lesions, like in case of MS, NMOSD, it becomes, it's highlighted. So that's the relevance of doing a flare. Then is the diffusion weighted imaging. Well, it assesses the restriction of water diffusion. So its prime indication is in early cases of ischemia, where you're suspecting an infarct. And the advantage is that even though the conventional MRI early in the phase of infarct may not show the change, it will be evident in a diffusion weighted imaging. So that's an advantage. Then comes the fat suppressed. Now fat suppression, in T1 the fat is bright. No, but when you have to look at the optic nerve pathology, you should get a fat suppression done. So you see bright fat in the orbits, you cannot visualize the optic nerves. But once you have suppressed these the fat, you can very nicely now look for the optic nerve and associated pathologies. So that's the advantage of fat suppression. Then comes your 3D Fiesta and CIS-scan. Well, this is a highly T2 weighted image and it gives a high resolution image. So for finer structures you can do that, like for imaging the cranial nerves or sometimes even cysts. Then MR spectroscopy. While MRI is giving you the anatomical details, the MR spectroscopy gives you the chemical composition of the brain structures. So you can differentiate between various types of, the differentials. Like in this case, the patient has a ring-like lesion, basal exudates. Now tuberculoma is confirmed because it shows a high lipid lactate peak and a low N-acetyl aspartate peak. Similarly, you have different biochemical, the various chemical, based on a chemical composition, you can also differentiate between glioma and a meningioma. So that's your MR spectroscopy. Now coming to each of these indications in neuro-ophthalmology. So first is a case of optic neuritis. Now if the patient has a very typical feature of optic neuritis, you can go ahead with a contrast enhanced MRI of the brain, flare images, and orbits, fat suppressed images. Then what do you see on the post-contrast enhancement of the optic nerve that confirms the optic neuritis? And on T2, you see these hyperintensities. So this is your demyelinating lesions. So this imaging not only helps you to confirm the diagnosis, but also helps you prognosticate the case. Because according to ONTT, if you have the baseline MRI shows these lesions, then there is almost 70% risk of progressing to MS. Now, if it's a case of atypical optic neuritis, then you should also add a MRI spine to your investigation, because you should rule out a transverse myelitis in such cases, okay? Now coming to optic neuropathies, whether bilateral, unilateral imaging is needed, especially in bilateral cases. A patient comes to you with such a picture, bilateral disc pallor, and again, you see this, basal exudates, ring enhancing lesions. So that shows, so a bilateral disc pallor indicates that the pathology is somewhere in the chiasma, or maybe in the tracts that's causing a descending optic atrophy. So it is probably related to this, like in this case, it's because of the tuberculoma, or it could be a bilateral optic nerve involvement, like in this case, it was a large sphenoid-side mucocele that was compressing the optic nerves. Unilateral pathologies, well, unilateral optic neuropathy, if it is a slowly progressive, then you have to rule out compressive lesions, okay? In such cases, you might also sometimes see the orbital signs like proptosis, dystopia, so that will help you localize where the pathology could be. Hemianopias, yes. So visual field effects respecting the vertical meridian, it's a very important indication for neuroimaging. So this kind of a field effect, you know where the lesion is. It's somewhere in the chiasma. So guide this and tell this to the radiologist so that he can screen that particular area and the radiologist provides you with the answer, okay? Then if it's a homonymous hemianopia, then where is the lesion? It has to be retrochiasmatic lesion. So in retrochiasmatic, it could be tracts and radiations or in the visual cortex. But if you see something like this, a macula sparing homonymous hemianopia, it has to be in the opposite occipital cortex. So then we have a case, 42-year-old male, was a known case of Takayasu arteritis. He presented with headache and bilateral sudden decrease in vision. The pupils and fundus were normal in this case. So neuroimaging is indicated. So we get a neuroimaging done, and what you see that the diffusion-weighted imaging shows this extensive bilateral occipital infarcts. So what could be the cause in a young patient? So this MR angiography was done. So whenever you are suspecting some vascular lesions, you should get angiograms or venograms. So in this, angiography was done. So you find this extensive here on the right side, you can see this intact channel of vessels, but here it's all gone. So carotid arteries, internal carotid vertebral artery was all thrombosed. So that led to an extensive infarct. In cranial nerve palsies, we have this elderly patient with a 6th nerve palsy. It could be a case of ischemia, but we got a screening MRI done and we found it was an internal carotid artery aneurysm. Then another case, but here with the 6th nerve palsy, you also see a lid edema and this conjunctival congestion. So this tells you something is in the orbit, probably in the orbit or nearby. So what we did was, and we found that there's a LR cyst. So it's a case of LR cysticercus. Now this is another interesting case. The patient was referred to us as a case of squint. This is a pediatric patient referred as a case of squint. On examination, we found that the child had dorsal midbrain syndrome because there was convergence retraction nystagmus and there was an upgaze limitation. So we got an MRI done and MRI showed a panhydrocephalus. But what's the cause? We don't know. Then in discussion with the radiologist, he suggested get a cyst scan done. And then we see this beautiful cyst lying in the ventricle. So that's the 4th ventricle. And this was actually a mobile cyst because it migrated from 3rd to 4th ventricle, and so it was a live intraventricular cysticercosis. And accordingly, the patient was managed by the neurosurgery people. This is another case. Congenital palsies usually do not need imaging, but what prompted her imaging in this case was that she has a right partial third nerve palsy. There was an extensive facial hypoplasia and also complaints of intermittent headaches and occipital headaches. So we just thought of to get an MRI done, and it showed that there is an enlargement of the posterior communicating artery, and you see also the hypoplasia of the right-sided midbrain, the affected side of the midbrain. Then again, the radiologist suggested get a cyst scan done, and we could not visualize the third nerve on this side. So then a digital subtraction angiography revealed that there was a bilateral segmental ICA agenesis that probably led to the hypoplasia of the midbrain and brainstem on the affected side. So these are the ideal indications for neuroimaging, but especially if you have a pupil involving third nerve palsy, please get a contrast-enhanced MRI with a MRA to rule out aneurysms. You can also go for a CT with the CTA, and orbital pathologies you can rule out. Papilledema, ma'am has already shown you. So get a MRV along with the brain and orbits because it could be space-occupying lesion or thrombosis, or if nothing is there, then probably an IIH. So just to summarize, remember that the key to diagnosis still is your clinical examination and communication with the radiologist. Do communicate to the radiologist what you are suspecting, what are the DDs, what is the suspected site of the lesion, and if needed, even if the MRI comes back to you as normal, if you're still suspecting something, go back and discuss with the radiologist because sometimes some subtle abnormalities can come up. Thank you.
Thank you, Dr. REBIKA. Now we have Professor Rohit Saxena with us, and he will be talking about optic neuritis.
Good afternoon, everybody. Good morning, actually. Still morning, and I'm sorry I was in another session, so I couldn't be here on time. So nice to see a filled hall for neuro-ophthalmology. This just goes on to show that how popular neuro-ophthalmology is becoming, and I'm glad to share that FICO has also started in neuro-ophthalmology, so eventually if you're looking for some form of certification, okay. If you're looking for some form of certification for